Welcome back, everybody. Tara Moncman, one of my partners down in our Florida location, will be the moderator for the next session. She's got a great group of panelists for you. So Tara, take it away.
All right. Thank you so much. Happy to be here. All right. So we're going to be talking about preoperative assessment and optimization, a little bit of focus on weight management, and in general, how you educate your patients that are undergoing total ankle replacement. So these are our discussion points. And I do want to thank our panel here. We have Dr. Erik Freeland, we have Dr. Omar Yaldo, and then we have Dr. David Watts, who's running a little late, but we'll see if he can get in here and join us. So what are our patient goals, right? Patients come in, they want a total ankle, but they want to be pain-free. They want to return to their ADLs. A lot of them want to return to a somewhat active lifestyle. They want a stable, braceless foot and ankle. They want to maintain range of motion, right? That's why a lot of them want to avoid the fusion surgery, and they want longevity. They want this to last. But what about our goals as surgeons, right? We want them to be a good candidate for surgery. We want the surgery to go well, obviously, without any intraoperative complications. Then once that's done, we want the wound to heal. We want no infection to occur. We want the patient to be pain-free, and then we want them to get back to all of their ADLs and to do some light exercising. And hopefully that survival rate of that implant is 10 plus years. And I think we think about all these things as surgeons, but sometimes what can get lost is what makes a patient a good candidate for surgery. So the ideal patient, right, is, in my mind, I don't know about you guys, but it's greater than 65. They're not obese, so a low BMI. They're low demand patients, right? It's like the grandpa that wants to be able to walk around with his children, someone who enjoys walking for exercise, and someone who has realistic expectations. But obviously that's not always realistic, right? And the AOFAS, put out a position statement in 2014. And basically they said that before considering the total ankle replacement, patients should have exhausted or failed conservative treatment, which I think most of us do, should have satisfactory vascular perfusion in the involved extremity, and appropriate or current or planned soft tissue coverage. So helpful, but not that helpful, right? Pretty vague and kind of obvious. So there's some patient risk factors that I think about: age, obesity, tobacco use, and diabetes. Do you guys have any other big ones that are key when deciding you're going to do a total ankle versus a fusion?
Occupation and activity level are huge for me as well, too. Those are really big factors overall. If they're too active or they have a high demand physical occupation, makes me think a lot more about going the route of fusion.
Yeah, that's a great point.
For me, I would say neuropathy, whether it's diabetic, chemotherapy, idiopathic. That's like something I'm always thinking in the back of my mind as well.
True. Yeah, I agree with you. Definitely a hard no with the neuropathy. So here's a patient who's 48. He has no past medical history. He played college football, so he has pain in all of his joints, particularly his left ankle and his right knee. He's active, right? He enjoys CrossFit, but says he's willing to give those things up just to have painless joints. He's had injections. He uses a brace. He doesn't run anymore. He really just wants, to have pain-free range of motion. These are his X-rays. So right off the bat, what are you guys thinking? Is he a candidate for total ankle? Would you automatically say he's in the fusion category? I'll go back to the X-rays. Would you make him continue non-operative treatment for another 10 years?
It's a great question. I mean, at 48 years of age, I try to get him to at least 50 typically.
Mm-hmm.
I don't know how much more 2 years is going to make a significant difference, but it's tough. You see a lot of these younger active individuals that are coming to us now with end-stage ankle arthritis, and a lot of them because of history of chronic ankle instability that they've had as a result of being an athlete when they were younger. So The real question is can you take somebody like that successfully to a total ankle replacement? Now, if he's otherwise, if he has realistic expectations as far as what he'd like to do at this stage in his life, if he's not trying to run marathons or be actively engaged in contact sports, I think given his age and with realistic expectations, and he's failed conservative care, I think you can successfully take him to a total ankle replacement.
I agree as well. I think if you have the conversation and just for them to know that they may be signing themselves up for a revision in the future or conversion to a fusion. And I even tell them, you know, you may even end up with an amputation when you're older. I think it's not unreasonable if they want to maximize their activity level for their current age.
Yeah, I agree. I think the patient counseling is huge and just really laying the groundwork. You know, you're probably going to need a revision in the future. You will need a revision in the future. The more active you are, the more likely this is going to wear through. Do you guys have any specifics in terms of what implant you'd use? You know, with a young patient, are you more apt to do a chamfer versus a flat cut? Does it matter? And then obviously, what's your opinion on concomitant procedures?
Yeah, those are all great questions. Even getting back to, backtracking a little to like the age, there's so much conflicting data that's come out about age. I mean, even the more recent study in JBJS from Duke that looked at, younger patients and patients less than 55, showing less optimal results. It still is a very difficult conversation to have with patients. But the way that I look at it and the way I present to patients as well too is, with doing a total ankle less than 50, what are you looking at as far as a secondary procedure down the line? Do you want, if we take this patient to an ankle arthrodesis, they're going to burn that subtalar joint out within 10 years. And so converting them then to a subtalar fusion on top of it, or essentially a TTC, is a tough sell. So, maintaining that ankle mobility and taking them to an ankle replacement, in my opinion, then having a revision down the line, especially with improved implant survivorship and now revision componentry is available, I think it's a very reasonable option to take this patient to a total ankle. And I would say if it was mine, I'd prefer a total ankle over an ankle fusion in that context. So, but I think, related to your question now, I think, looking at implant, I think in my opinion, still a stem tibial component is superior. I think if you can, without disclosure, doing a stem component, I think actually can, we know that there's base plate loosening issues in some of these components that are out there. I think if you can have a nice stem tibial component, I would prefer that along with the chamfered talar cut. And then concomitant procedures, I would try to do everything I can to avoid anything related to the subtalar joint. I think that you could argue that there's some change there on the x-rays you presented, but I would try to leave that alone.
Yeah, I agree with you. So he wasn't having some talar joint pain. He was a little flat when he stood. So, this was the very first patient I ever saw in practice. So I pushed him as far as I could for a full year. I had him continue with conservative management. And then we did end up doing the total ankle. And then I did a slide just because he had a little bit of a valgus heel. I think I agree with you. The thought of the stemmed implant, I've been more and more interested in this. I think it definitely provides so much more stability. And then in terms of flat cut versus the chamfer cut, I went back and forth with this implant. The flat cut, it's still taking the same amount of bone. Yes, you do save a little bit more on the gutter, obviously. But I ended up doing the Infinity with the thought that I could convert to the stemmed implant in the future because it has, the revision. But this 1 year out, he has no pain, but he is doing box jumps again, and he's definitely more active than he promised he would be. And I don't know, he's not presenting with any clinical symptoms suggesting loosening, but I see even on that tibial component, like that little lucency along the top. And I don't know if he's having a little bit of that rocking horse phenomena, something I guess we'll just have to keep watching. What do you guys think?
I think it looks excellent, Tara. I think I would have approached this case exactly the same. I don't really like to jump to a stem if there isn't any previous tibial trauma, cysts, if I can essentially get away with not using it for the same thought process that I can always come back and end up putting a stem in if there is failure. And I agree. I like the heel slide, especially given his age. I do find that if they have some rigidity, I am not as hesitant as I used to be with regards to just doing a triple beforehand, but certainly not in a 48-year-old.
Yeah, I think it looks great, Terry. You did a wonderful job. I think I agree. Adding the concomitant osteotomy, given his flat foot deformity, I think is helpful. In my opinion, it's something easy to add. You can even do an MIS, and it doesn't add a lot of time to the case, and it still doesn't really. The only implication, of course, is weight bearing, but we know we can let these weight bear at an earlier stage too. So.
All right. And again, I think we touched on this a little bit. How do you counsel the patient? You know, definitely with these younger patients, even like 65, I don't know about you guys, I say you could need a revision surgery at least once, right? With him, he might even need two. It kind of just depends on how much he's doing. What do you think about like water skiing or skiing itself where they're locked up in a boot? You know, it can still be pretty high impact though, but I have a lot of patients who water ski down here in Orlando and at all ages. And then in the summer months, they go up and they ski. And you know, what do you guys think? Is that a hard no for total ankle, or you think it's okay?
It's not a hard no for me. Personally, I think I've had some few patients with fusions in the past that have tremendous trouble getting into ski boots. They have to get rear entry ski boots. I don't have any data on it, but in speaking to our colleagues in ski towns such as Vail, they've been doing these in patients for quite a while and haven't had any major catastrophes that I'm aware of.
Yeah, I agree. Up here, it's with snow skiing, and I agree with what you said, Omar. Trying to get into the boot is very, very difficult for patients with ankle fusions. They have to get special or customized boot in order to do so. But yes, the up and down pound, the impact that they get with going over small moguls or wakes, it can be challenging, but it's not a hard no for me. But I think you have to counsel them on, maybe limiting some of their activity that they're doing.
Definitely. And that's kind of what I tell them, right? Like, I don't need you going off any major jumps, but if you just want to do, some basic water skiing or, slope skiing, then that's probably okay. But for me, like, again, running, the high impact training, repetitive jumping, I tell patients like no more, like you're guaranteed to fail. And who knows when that will be, within a year, a couple years, either way. I think it's just too risky. At least for me, I make that pretty clear. And I also tell them that, like the more active you are, the higher risk for a revision. But my big thing is, right, when a patient comes to me in their 50s, they may, be putting more stress on the implant, but they're in their 60s, they're going to be less active, in their 70s, 80s, even more less active. So I think there's a chance, even with, I see patients that had totals done when they were 60 and now they're 80, and, maybe there's some recurrence of some osteophytes. The gutters aren't as clean anymore, but they're still doing pretty well. What about you guys? Are you seeing patients who have had implants like a while back who come to see you just to check in and see how things are? And while maybe the implant looks like it's subsided a little, or maybe there is some osteolysis or there's a cyst, they're still clinically doing pretty well?
Yeah, I would see that routinely. They would come in. They had another implant done 20 plus years ago, even in some cases, and they would, you would look at the X-ray outside of the room, and you would see just things that you mentioned, osteophyte formation or subsidence, and you're going to the room thinking, that you're going to be talking to them about a revision, but in sense, they're really doing well clinically, and they just really came in to get things checked up. And so you're always kind of pleasantly surprised, even though radiographically speaking, it may not be less than ideal. Clinically speaking, they're doing quite well. But like you mentioned, at that age, they're less active and their expectations are much different too. So.
Yeah, it's interesting. There's just, I don't think there's one answer. It's just all about making sure patients know that there's a chance they're going to need a revision surgery. And I think that's the big thing about counseling patients and just setting that bar and making sure their expectations are appropriate. All right. let's talk about the opposite. So a 77-year-old man, I wouldn't say that's old, but older, you know, he's got some medical comorbidities, really functionally limited. He can't stand or walk for more than a few minutes, and he's got frequent falls because of this sense of instability or just being off balanced in the foot and ankle. And then these are his images. So pretty severe deformity there. And and a bigger guy. I didn't put that in there, but big and tall, I would say. So again, what would you do? Just keep him non-op, ankle fusion, ankle replacement. Just tell him to live with it. He's lived with it for this long. I'll go back to the x-rays. Is he a candidate for a total ankle?
Yeah, I think so. It's, you know, certainly, I mean, he has incongruent varus ankle arthritis, but 70 years of age. If you failed conservative care,
77.
77, okay. At that point, yes, I think if he certainly seems like he has reasonable expectations. I think I would consider a total ankle replacement, probably non-stem component with chamfer cuts, and can even have to consider augmenting that with a brostrom repair too, given some of the incongruency. That's what I would counsel him on.
I'm in full agreement there. I think he's an excellent candidate. I think ultimately it appears any of his deformity is coming from the level of the ankle joint, but that's the other thing I'd consider is if I can correct his deformity clinically and seeing the way his foot looks when I do that, and then plan out any other procedures along with it.
Yeah, so it's so funny because I chose a stem because of that varus deformity and because of his age. I felt like this will stick with him forever, gives him some more stability. I'm curious, why the non-stemmed component?
For me, I was looking at longevity. I think given his age, you know, non-stem components, it's just a little bit less operative time, a little bit technically easier to do.
Yeah.
I figured that it would work, but I think you're absolutely right. You worry about in the varus ankle, though, especially when it's incongruent as far as edge loading and whether or not that's going to enhance base plate loosening. But
yeah,
you know, I think you're not wrong. I think this looks great, and I would, you know, given the fact that we can do PSI and now with, you know, the 3D printed instrumentation as far as being able to do these quicker and easier, you know, you could do this very successfully like you had, for sure.
Awesome. So do you guys think there's an age that's too old? You know, my colleagues who are hip and knee surgeons are doing hip and knee replacements in like 95-year-olds. What do you guys think about the ankle?
For me, there's not a hard cutoff with age. It's more so the skin quality and the soft tissue envelope quality. And when we're starting to get close to 90s, if it's a patient that if they had an ankle fracture and I would consider a TTC nail as their traditional fixation, I wouldn't be comfortable doing a total ankle on.
Yeah, that brings up a good point. Do you guys send like older patients who have all those vascularities, you know, they just have that like thin skin, you can see all their veins, for any vascular studies?
I do if I have any gestalt, like if it's a male patient without hair on their legs, or if they have significant varicosities or discoloration, I don't hesitate to. But I'm in a system where it's very easy to obtain that and send a text out to the vascular surgeons and get them in quickly.
Yeah, I do the same. If for everything that you mentioned, Omar, I'll send them for a vascular assessment too, if I'm really considering a total ankle. But you know, I do worry. I don't have a specific age cutoff as far as on the higher end of that spectrum, but I certainly do, you know, really, you know, do everything we can to avoid surgery in the elderly, especially if they have that real thin, frail skin anteriorly, which I would worry about breaking down.
Mm-hmm.
And I would say too, planning potentially prophylactic medial malleolar fixation, just because I've seen it and it happens more often in my hands in elderly patients.
Yeah, I think that's another great point. What about prehab? Do you send them for any like therapy beforehand in you know, knowing that they're going to be about, you know, 6 weeks maybe non-weight bearing, they're going to decondition a little bit?
I'm not routinely doing it if they've truly failed conservative management otherwise. However, a lot of the insurers in my region are requiring it. So that's the case when I am sending it. But if it's someone that's significantly older, I find that they end up going to rehab after surgery anyways, depending on their home situation. And that ends up being kind of a post rehab for me that I wouldn't normally otherwise do.
I've seen the same trend where it's an insurance authorization now for the total ankle. A lot of times is now requiring a course of physical therapy. So in that setting, I will, but I don't see a significant advantage in doing so beforehand, typically.
Yeah, I don't either. We also down here, patients often have really high copays, and they worry about running out of their therapy visits. So we try to just, save them. But and any other special counseling points with the older patient, someone 85 above that you
I
can
really counsel them on the skin issue. I think that's incredibly important. I've run into a lot of skin issues after the age of 80.
Yeah. Yeah. Is there anything you do beforehand, or what about like post-op? Do you do anything particular with the skin when you close? Like with your suture or wound vac or
I've started using Celerate, which is a collagen product for skin closure. I don't think I've used it enough to see if there's a difference in the patient. There's some literature on it.
There's a study by Haddad et al. Regarding a compressive wrap for his total ankle patients that showed he got a decreased wound rate. So I tend to try to mimic that in anyone where I'm worried about their skin, just by having a compressive wrap underneath their splint, essentially.
yeah.
Yeah. I used drains early in practice. I didn't find any significant advantage to that, and I think the literature now supports not using them. But I'm really particular about applying a compressive wrap, even with still the tourniquet up if we can, and then let the tourniquet down after. I'll keep them really in dorsiflexion to make sure that that all the web roll lays nice and even on it, so there's no extraneous pressure outside on the from the splint over top of the wound.
Yeah, I do something similar. I bring them back after a week, actually take down my post-op splint and then I put them in a Una boot dressing. And I don't know. I think that helps. It's a little compressive. But all right. And then we'll just look at the literature a little bit. So this was a study done at Duke in 2015, and they looked at age and 395 patients, 3.5-year follow-up. And they had 3 groups: less than 55, 55 to 70, and greater than 70. And they had the less than 55 had the greatest improvement in function, but overall there was no difference in pain or complications. So that was a good one in support of younger patients. Another one, same study, but pushed it out 5 years, had a 6.4 revision rate. And again, no association between age and revision rates. This was another smaller study, 51 patients, all less than 55 with almost 3-year follow-up. And they also found no major association with age. This was a bigger study, JBJS in 2022, and they did find that age was a risk factor for complications and revision implants. So mixed evidence out there, as we see with most things. I think it's probably all about taking each case individually and using the best information you have at hand, but all good, interesting talking points. So thanks, guys. All right, let's move to tobacco. So you have a patient that smokes cigarettes. Is that a relative, or smokes tobacco now because everyone's doing their e-cigarettes? Is that a relative contraindication, absolute contraindication for total ankle replacements?
Absolute for me.
Yeah.
Yeah, absolutely for me. I mean, it's something that they with appropriate counseling, they can abide by a smoking cessation program, and and you know, I think if you heed enough warning to them, they usually are scared enough to stop. And those that I don't necessarily trust, so I will test them for continine levels too.
Yeah, if you tell them, you know, you need to quit, what do you tell them like that day at their preoperative visit? You know, do you say at least a month before? Do you have a number? You know, I looked and I didn't see anything in the literature to really help us with that.
I try to do 90 days before, and even, but I'll accept 60. Depends on the quantity or how often they're smoking too. I think that plays a factor into it for me. Like just given their overall pack year history, I'll take that into consideration. But I will in those heavier ones, so to again test them for sure. And for me, it's 60 days minimum, but try to get them out 90.
And then how about afterwards? Is it indefinite? Is it just until the, obviously we all want them to be indefinite, but is it until the wound closes? You know, how do you counsel them, I guess?
I tell them 6 weeks post-op because you've got wound healing and ingrowth of the component at that point.
Yeah, same.
And then that nicotine test pre-op, I've used that a couple times. I think it's helpful. Just, I think the threat of getting that nicotine level makes them, you know, stop smoking. You know, I would say with total ankles, you know, I'm early in practice. I'm pretty cautious. I don't really trust that they're going to stop smoking because I've done this with other procedures where, you know, they say they're going to stop and I, you know, they come into the room and you can smell the cigarettes on them. So I don't know. So for me right now, it's a pretty hard no. But maybe as I get further out, I'll, you know, do more of the counseling and get them through a tobacco cessation program. And then, you know, the literature pretty much supports what we've been saying, right? We know that there's a higher risk that they're going to have an increased wound breakdown. And this study actually showed they had lower improvement overall, but former smokers had a similar improvement to non-smokers, which is nice, which is more supportive. If you can get them through that tobacco cessation program, they might do well. So final answer, you guys, tobacco use, just non-op, no total ankle, or proceed to the OR?
Non-op.
Yeah.
Yeah, not up until they stop.
Yeah.
And I agree with you. The test holds them accountable, which is I think the best thing about testing, actually.
Yeah. Okay. And then diabetes, right? What's your number for hemoglobin A1C?
7.
Agree, 7. If it's someone that like came down from a hemoglobin A1C of 11 and they're 7.2 a couple weeks away from the procedure, I will still do it if they've made a big jump and are headed in the right direction.
Neuropathy, I think we touched on that before. For me, that's obviously, that's a contraindication. I think we all said the same. Any other education programs? Like, do you guys make them get endocrine, you know, clearance, preoperative? You put them on a special nutrition program or have any recommendations for that? Or is it more so have the primary care team manage that?
I'll defer to the primary care team, but if they're look at the trends in their A1C level and their blood glucose levels, and if they're well controlled and there hasn't been really any significant change, then I feel good going forth without any specific educational program. But if they're up and down and they've had some recent changes in their medications, I'll make sure they see an endocrinologist and more defer to the primary as far as educational programs related to blood glucose optimization.
For me, it's just looking at their meds. I mean, if they're a type 2 diabetic, they're on insulin, having to do multiple things, multiple medications, they're going to see endocrine pre-op. Otherwise, their primary can manage it.
Yeah, agree. And then, you know, there's a few studies out there looking at diabetes with total ankle replacements. This was a big one, 813 patients, only a year follow-up. So it's always hard to tell, you know, with just a year follow-up. But they found no difference in revision rates or secondary operations or infection. this was another one in JBJS in 2014, minimum 2-year follow-up, and they saw that diabetics had a decreased survival rate after 36 months. But if they were a controlled diabetic, it was basically equivalent to not, a patient without diabetes. So I think diabetes, control is key. And like, you guys talked about, I agree, hemoglobin A1C of less than 7. And then here's another one in 2015, large database study, and they saw diabetes, showed a longer inpatient stay, higher discharge to like a skilled nursing facility other than home, and increased risk of complications. So, all right, and now for the main one, obesity, which I think is tough. So you guys have a BMI cutoff?
I don't. I look at their overall body habitus too, as far as their height and their overall weight. I'm not a huge necessarily believer in the BMI, but I think you have to look at their overall just body habitus for me in general.
Yeah. What about does your practice have a cutoff, or your hospital or surgery center?
No, but insurance companies do, and that's one
Yeah.
of the pushbacks. So you'll see if they have a high BMI, the insurance will basically cut them off, which, some of that's based on arbitrary data is when they, based on a, FDA approval from the STAR trial initially. But so sometimes that's very difficult to overcome, and you'll have to end up doing, like I've had to do a few times from peer to peers and talking to someone on the insurance company side to gain authorization.
Yeah, our practice has has to be less than 50, which 50 is pretty high. But it is nice, at least when you have those patients, I guess, that are above 50, you have kind of like a limit there. But there's patients that come in with the 48, 49, and it's not like the big and tall person, right? It's like true obesity, and I think it's a tough conversation.
It is. But I think you can counsel them on weight loss and see them through that a program, and typically if they're motivated enough, they will. But it's a difficult conversation oftentimes.
Definitely, and we know in the hip and knee literature they've done a lot with obesity, and it shows increased risk of wounds, infection, revision rates. I think I'm seeing more and more studies on obesity and total ankles. But I think what you said, what if the patient, right? BMI isn't everything, right? What if the patient's just, 6'8" and big muscular person, right? Is that, what do you guys think about that? Like, as opposed to like obese, maybe increased comorbidities. Is there a difference, or is it just the patient's large, so they're going to be putting stress on the implant? So, that means there's an increased risk.
I think there's definitely a difference in the bone quality when you're operating those patients that are obese versus not obese. The large farm guy with the BMI's got good supportive bone versus the 55-year-old gal that's got some extra weight on her and walks maybe a couple miles a day.
Yeah, I think that's a really good point.
I agree. I think where they're carrying the weight plays a big factor too. And any patients with true lipedema or lymphedema, those are all hard no's for me as well.
Yeah, that's a really good point, actually. I agree. The lymphedema, even I've tried to send some patients to lymphedema clinics to try to get it managed, but I'm still very, very, very wary about doing a total ankle on a patient.
Agree.
Okay, so what about your practices? Do you guys have nutrition counselors in your practice, or a preoperative weight loss program, or do you guys have affiliations with bariatric surgeons, or how do you go about counseling these patients that come in that are truly suffering, have really bad ankle arthritis, but they technically fall into that obese category?
Well, so I'm new at my institution at this point, and so where we're at, there is a high volume joint arthroplasty practice, within, and so they they do have these programs that are available to patients, and currently I'm getting tied into those right now for patients that are considering ankle arthroplasty.
Yeah, we have nutrition counselors, and we're trying to put together an optimization clinic to kind of help these patients. But I think, you know, it takes a lot of organization, right? And a lot of communication, and patients then they need a lot of follow-up. And this, I think the hardest part too, is this could take a year, right? To get a patient to appropriately lose weight. And I think that can be tough too. What about Ozempic? Has anyone recommended Ozempic to their patients? I have lots of patients who come in on Ozempic now.
I haven't necessarily straight up referred it, but I could have, you know, people come in asking me about it, and then I'll of course defer to the primary about, you know, about potentially putting them on that. You know, what I worry about some of these gastric bypass patients, are they malnourished in a degree too? And so I do, if they've had a history of that, I will have them talk to a nutritionist and just to get more input as far as whether or not they feel like they're nutritionally optimized to undergo a big procedure.
Yeah, I think that's a great point. That was my next question. Do you guys get, right? Because sometimes these obese patients are actually malnourished. Do you guys get any nutritional labs beforehand?
Probably should, but don't.
Yeah.
It's difficult because I don't know, like, you know, what are we looking at specifically as far as that panel of labs? Like, you know, we're looking at serum albumin and prealbumin, and so does that help? A lot of people, you know, the nutritionists you talk to say it doesn't. So it's very difficult. I lean on, you know, nutritionists' input for, you know, just to give me an overall idea whether or not they are optimized, but it's difficult. I don't think that we have a great answer for that.
Yeah, I agree. Anytime I do order, I think the prealbumin, the albumin, it's always, I don't know, it's always normal. Maybe that's a good thing, or the patient is healthy enough, but I'm not sure what it really shows. I agree. But definitely an interesting point to consider. And then, you know, these patients are also, if heavier, you're going to make them non-weight bearing. They need to use a knee scooter. Sometimes they can't. Do you ever send them for just, you know, some preoperative physical therapy just for gait training and for when they're going to be non-weight bearing, so they can see how difficult it really may be?
I've done that multiple times.
Yeah.
I will do that too, depending on the patient's overall disposition at home and whether or not, you know, always ask them questions pertaining to how many stairs they have, what's their home environment like, and try. And a lot of times I will send them physical therapy for that initial optimization, so they can get acquainted to using a knee scooter. Because a lot of them, you know, obviously they come in, they're pushed out oftentimes same day, so they don't have much opportunity even at that point of care post-surgically to really optimize things for their home environment. So I try to get them keyed in with our physical therapist early for that, even if it's just one visit.
And I found that often comes up in the preoperative conversation when you start talking about non-weight bearing. You get the patient, how am I supposed to do that? And that's when I'll introduce physical therapy as the solution to that problem.
Yeah, I agree with you guys. I feel like that is just like an absolutely imperative conversation to have. And even though it takes a little bit longer, I always, you know, spend just the extra couple minutes just talking about, you know, non-weight bearing and what that means, right? Like, even if you have a step or two coming into your house, like if you have a knee scooter, you're going to have to figure out how you get that knee scooter into the house. And so I do the same thing. I'll send them to therapy for a session or two, whatever they need, just to make sure they see what they need to do and not I don't want to set them up for failure, basically. So I think that's really important and a good takeaway point. And then, you know, there's been some studies, again, this one out of FAI in 2016, 2-year follow-up of 455 patients. And they looked at, you know, non-obese, obese, morbid obesity, and found no significant difference in revision rates, and all groups improved in terms of pain and function. But the obese patients had less improvement. And I think there's a few studies that show that. And that's because they started out So while they had less improvement, they also started out with lower initial scores. So I think that's something to take into account. While they don't have as high of scores as the non-obese, they still improved based on their preoperative scores. And this was another one in 2016, smaller study with 91 patients. This one showed that patients that were obese greater than 30 had a higher risk for revision. This was another big study in 2023, so more recent and with a minimum 2-year follow-up. Again, looking at obesity, and the implants used for the implants used for the obese patients actually were more in bones and Vantage, just because for the stability aspect. And then they found no significant difference in post-op complications. And interestingly, there were 10 infections, but no infections in the greater than 35 BMI group. Most of them were actually in the control group. And then no difference in implant failure, just other than age, actually. And then they did find, similar to the other study, that obese patients did report lower musculoskeletal function and quality of life compared to the non-obese. But again, they still had an improvement, a statistically significant improvement compared to their preoperative. So I think those points are it's kind of interesting, these study results. So when you think about obesity, you worry about that increased weight on the implant, right? You worry about the wear through the poly, increased stress, even subsidence. Why do we not think that it wears through as much? You know, we see that you don't get that like poly wear like you get in other joints. So maybe that's not. What do you guys think of those study results? You know, do you think a big patient wears through their poly faster? Do you see that at all?
Can't say I've seen it necessarily, but I do agree with the theory behind that. You know, it's with, you know, activity, weight as a whole, all of these things overall, I think it's going to wear down quicker. So, you know, the question is do you put in a bigger poly? I don't necessarily say that, but it's something I do have given thought to.
Yeah, I think sometimes maybe they are bigger, more stress on the implant, but sometimes these bigger patients also they aren't as active. So maybe that's why they're not like wearing through, and there's not this major increased risk of revision surgery. But I don't know. It's all speculative, right? And then in terms of not having, you know, increased wounds or increased risk of, or increased infections in the literature, maybe that's because your patient could be really top heavy, but I find that the ankle is sometimes like it's small, right? And it's surprising how small the ankle could be in some of these really big patients. And maybe that's why the wound complications are a little bit less. And then this last study was it was a big review looking at 10 prospective, 27 retrospective, international study. Majority were from the US. And they found that 2 of the studies found that their high BMI was associated with an increased revision rate. And then there was another group of 6 studies that showed, again, higher odds of revision with obese patients. So I think the literature is pretty mixed. And that's it. That's what we've got. So in summary, I think in terms of age, young patients, it's okay, but you always got to counsel them. They'll need a revision. We need more long-term data. Obesity, I think it's still up for debate. Beware that they may have an increased risk of revision rates and worse improvements, but still improve. And then I think we all agree that tobacco increases the risk and diabetes also increases the risk, but it's okay as long as they're controlled. You guys have any other good points before we finish up here?
Question for all of you guys. So, you know, the joint guys have BMI cutoffs, and they'll then recommend patients to go get, talk to weight loss surgeons, things like that. GLP-1s have changed all that. What are your guys' thoughts? Do you do that? Do you like that idea? Don't like it? Do you care? What are your thoughts?
Yeah, I think, you know, the GLP-1s, like you mentioned, I think have really been a game changer for sure. But you know, it'd be interesting to see long term, the effect that they may have on their overall nourishment and whether or not that has a factor in this as well. But I don't have that hard cutoff. I think it's the overall looking at the bigger picture, rather than just implicating to say to BMI like a lot of our arthroplasty colleagues talk about.
Yeah, I think it's interesting. More and more patients come in on it, and I just don't know if we know enough yet.
Right.
I just have one comment on a specific pre-op medication that I ran into a problem with that is not common. So there's these angiogenesis blockers that are now on the market for treating cancer patients, and they do have some off-label uses. I had a patient that was on it because of, I forget exactly what her condition was. It's pretty rare, but she was on one of these angiogenesis blockers. I did not. I had to do a pre-op, did not recognize the medication, and ran into a wound healing problem. She didn't lose her ankle over it, but she ended up having exposed anterior tibialis tendon. Took about 6 to 8 months to heal it with wound care products. So I think it probably behooves us to look at some of those and familiarize ourselves with them.
That's a great point. Great point. But it also begs another question. I wanted to know, what are you guys, because we have some time, what are you guys doing for your wounds? How are you closing them? And are you doing anything to try to minimize that anterior wound healing issue?
I do Rudy Allgauer sutures. I'm not sure what everybody else does. I know actually Steve Haddad, I listened to him talk on his wound care once, and you guys were talking about splinting in dorsiflexion. He actually splints in plantar flexion. He feels like there's less stress on the skin. I don't have literature to support that. I don't personally do it myself, but I remember him talking about that specifically.
Interesting. I do horizontal mattress, and then I use like a Pico wound dressing, so like an incisional wound vac, splint, and then I bring them back a week later, do an Una boot, and then bring them back like 4 or 5 days later, and I put them back in a splint, and I take my sutures out at 3 weeks. So I used to take them out like 10 days, 14 days, and now I do 3 weeks, and I feel like it's like I just feel so much more confident putting them in a boot, letting them do range of motion. It's
and
annoying.
I will say this,
really
I started
annoying,
with the agility ankle back in 2005. We had much larger wounds back then to put that ankle in. And my wound complication rate with the newer ankles is significantly lower with the smaller wound.
Yeah, I agree with that. I mean, for me, early in practice, I was doing incisional wound vacs. I would use a drain. I slowly moved away from that as I had developed more confidence with my closure. And it was just a full layered closure, making sure to close the extensor retinaculum so there's no bowstringing from any of the extensor tendons if that happens to be an issue. I'll do 3/0 nylon horizontal mattress fashion. I put Vanco powder in the subcutaneous portion of the wound to help prevent infection as well too. And then really splint them in dorsiflexion with a full compressive, compression, but making sure that there's no wrinkles or anything. I'm really making sure that everything lays down nice and even. And then I bring them back at 2 weeks, take the splint down, take the sutures out typically, and allow them to go into a boot at that point.
I'm in the same boat. I do horizontal mattresses. And then ultimately for me, I think the compressive wrap is kind of my only other thing. And it's essentially, I do zero form 4x4s, 1 layer of web roll, an ace wrap, and then I pad it up with more web roll and place the splint.
Have any of you guys played with or used those zip closure devices, or there's a variety of different of those ones out on the market now, and it's many joint guys use it. Have any of you guys used those for your closures?
I've not used those on total ankles. I have used those occasionally on different like wrist fractures and other things, but not total ankles.
I use them routinely on my total ankles. I think they've made a difference on wound complications, but also on the appearance of the scar after it heals. It's pretty remarkable, I think. Question came in. Everyone using TXA? I should flip that. Anyone using TXA?
Yep.
I don't, but
I'm not.
Yeah, I'm not. David and Omar, why are you guys using it? What are your thoughts?
Just to decrease bleeding. I'm not worried about the overall blood loss. I'm worried about local blood loss and perhaps it controls that somewhat.
I'm worried about local swelling, and if I can prevent that.
Okay. There's another question here. Are there, and somebody wrote, and I'm trying to understand this, is there an approximate 3-inch spacer of any kind that could be put in the joint before a TTC nail to minimize the shoe modification required?
I think she was referring, she had asked a question beforehand on revision ankle arthroplasty when there are no revision components available. I don't know of any spacers. I try to build that into, if I'm doing a femoral head allograft or a custom cage. You can work with some of these 3D printing implant companies to give it your best shot.
There were some questions on steroid. If you do a steroid injection, how long do you wait? And I think most of us agree at least 3 months.
I agree with that, 3 months.
And then there was a question about biologics for rheumatoid. I do 2 weeks off, 2 weeks before and after.
Same.
I'm the same. And if I have any questions about specific agents, I'll defer to the rheumatologist.
What do you do with methotrexate?
I let them stay on it, but I don't know.
I do too.
I do too on metho.
I treat it like a total knee or a total hip. There's the American College of Rheumatology has published guidelines on each biologic that's out there. And then I wait till their wound heals before I let them restart.
Yeah, I wait till the wound heals. I tend to be a little bit more anal. I've seen issues even with methotrexate. So even though the recommendation is that they can be on methotrexate, I personally have just pulled them off of it. But we all learn from our experiences.
It's true.
Cool. Any other questions you guys have?
It looks like someone asked, when do you weight bear them? But I think, do you guys change your weight bearing status based on any of the things we talked about? Like if you have a younger patient, older patient, you're worried, any of those things?
I've been kind of a stickler for 6 weeks, but I'm willing to consider less weight bearing, period.
I'll let them, I typically, if there's no associated concomitant procedure, I'll let them bear weight at 2 weeks, but it also depends on their overall activity level though, too. If they're one of which that they're on the younger, more active side, I'll hold them back a little bit longer just to protect them from themselves.
Yeah.
What if you're doing an associated lateral ligament reconstruction? What are you doing then?
I'll still let them bear weight at 2 weeks in a boot. Depend on the amount of instability though too. If they had a significant amount of instability, then I will hold them back a little bit longer.
And when you guys do, for all of you guys, when you do associated lateral ligament reconstruction, are you putting in any kind of augmented device in there? Dealer's choice of which one you want to use, but are you guys using that?
I've been using the internal brace.
I do if there's enough talus left underneath for me to get it into.
Right.
Yeah, I will as well too, depending it depends on the amount, their tissue quality and the overall amount of instability, whether considering that. I always find going into those incongruent varus ankles though, that sometimes you feel like you're going to have to do it, and then you're pleasantly surprised once you trial that you really don't. So it's become, I feel like less often than I expect even, that I'm going to have to do an associated brostrum.
It's the valgus ones that'll fool you.
Those are the tough ones, yes. Those are the ones I found being more aggressive with as far as augmenting them with a deltoid ligament repair, usually with augmentation.
Awesome. I think, Tara, you got all the questions. Anything else before we wrap up then?
Do you guys ever factor in their anticoagulation and that's effect on wounds? I think in my hands, when I see a gastric bypass patient, they're already poor nutritional status. They can't take aspirin and have to take like a Lovenox or something that affects their wound. I'm much more hesitant.
Yeah, I mean, I don't love any of those agents, and I try to do aspirin, but some of those patients have, with their existing medical conditions, you've got to go back on some of those meds somewhat sooner than you'd like.
What timing, when do you guys do that? Are you okay with them going the same night back onto their medications, or do you wait a day or two?
I just wait. I say the next morning.
Next
And
morning
like,
for me too.
yeah. I wish it could be longer sometimes. I worry about that like hematoma, but
Mhm.
All right. And then I think we'll do one last question. Are you guys using hoods or not?
Absolutely.
yes.
I don't.
We're split down the middle.
Literally down the middle.
Down the middle.
Yeah.
All right.
Do you
Well,
wear a
thank
hood?
you. Do I wear a hood? No, I don't. Don't wear a hood. There's no data, at least for foot and ankle, there's no data to support that it really makes a difference. So
It's the only chance our workers get to see our smiling faces in the OR.
I guess there's one last question that came in. How do patients with osteoporosis do with healing of bones and wounds?
I do find it takes longer with osseous integration, particularly on the tibial side, for those that are osteopenic or product. But I think optimizing those patients beforehand is important too.
All right. Awesome, guys. Thank you so much for getting up early in the morning. Appreciate it. We'll wrap up and then we'll start in 4 minutes on the next side. Thanks, guys.